I welcome you all. I have to make this official announcement. This part of our seminar is funded through HRSA grant. This is our 11th year, and we have 2 more years in this grant cycle. And so we will offer some continuity to this project at a regional level in terms of getting the word about telemedicine. It's a huge pressure on us in terms of what the current federal mandates are in terms of trying to incorporate telemedicine and telegenetics into our services, or at least start exploring the issues. There are a lot of bugs to be worked out, so this is just the beginning of the dialogue, and I'm so excited to see so many of you here. And our presenter, I'm going to have Lockie Armand, our project manager, introduce our guest speaker today. I think we are very exciting. I think he needs very little introduction, but we will, for the sake of people who have not had an opportunity to meet him, we will introduce Lockie.
So Dr. Flannery, he is the medical director of the American College of Medical Genetics and Genomics. So prior to the position, he worked with Medical College of Georgia, where he served in a variety of clinical and academic medical staff leadership positions. This included professor of pediatrics, chief of genetics division, and medical director for pediatric care. He received his medical degree from Emory University, and his topic today will be the Telemedicine Experience, and his presentation will be followed by a live demonstration by Georgia Telehealth. If there are any questions after the presentation, please raise your hand and we can pass the mic around. There's also pre and post tests on your chairs. Please fill out the pre-test before the presentation and the post-test after the presentation. Thank you.
The message is you want to do bad on the pretest. Don't try. Just like random, okay? Do I just have to go ahead and start this? Okay, good. All right, thank you. Well, it's fun to be here again. It's been a long time since I've been at Emory, although I did go to medical school and did my first 2 years of residency here. I did come occasionally to visit the genetics folks here. Can you hear me okay with this microphone? Is it doing all right? Good. Do you want to check for the off-site people? One thing I'll point out is I'm not only medical director for the American College of Medical Genetics, but I'm also technically the medical director for the NCC as well. Yes. So I'm doing NCC business here.
They may not know what NCC is.
The National Coordinating Center for Regional Genetics Collaboratives. SERC is one of the members of that. Are there 7? 7, right. Okay. It sounds like an echo. Can you hear me okay? Wow. Whoa, okay. I thought about calling this Experience Telemedicine. Oh, that sound? Ooh. Yeah. Can you hear me now?
I can ask everyone on WebEx if you could please mute your telephones and
that's what
computers,
it is.
please.
So we have several other sites who are linking in, and that's what's probably causing.
How's this? No echo? 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 No. Okay. Thinking about the Experience Music Project in Seattle. Have you ever been there? It's this amazing museum that Paul Allen gave the money for. It's really quite remarkable. Okay, my objectives are what telemedicine is, how it's been used for genetics, how telemedicine may be useful for future services, and talking about considerations for how you would set up a telemedicine service. I have to make a disclosure that I'm a member of the board of directors of the Telehealth International Partnership, which is a subsidiary of the Global Partnership for Telehealth, which is a not-for-profit entity that originally started off as just the Georgia Partnership for Telehealth, which ran the network in Georgia. The Georgia network got cloned into Alabama and into Florida, and then there now is a subsidiary, which is an international subsidiary as well. So I've served on every board. I've actually worked my way down the org chart to the subsidiary. Here's the Southeast, and you know, as I know, that we have few concentrated areas where there are geneticists. You know, so you got folks in Atlanta and Birmingham, Mobile, just a few handful of places. And we had lots of patients, and the land area is huge in the Southeast. Georgia is the largest state in land area east of the Mississippi, for example. And so there are barriers to access to our services, and you all know what they are. You know, the large population in rural areas, you've got Medicaid programs that could provide transportation, but they don't have funding necessarily to cover that. There's inconvenience of the distance of traveling, and then there are financial issues as well. And so, you know, so what's a kind of way we can address this access issue? You know, I could use technology. And you know, when I was a kid, you know, I look forward to technological advances like flying cars, and I love the Calvin and Hobbes cartoon here, like we're the rocket packs, you know, like the flying cars. We don't even have driverless cars yet, you know. And you know, the future of medicine, obviously, in Star Trek, we saw it. The tricorder diagnosed you. You just wave it over you. And then we had the transporter. And wouldn't it be great if we could have a transporter and we could transport patients to the specialists, or vice versa? And so actually we do have that now. Telemedicine does this. Now there's an official definition of telemedicine, and it's this here, which is the practice of healthcare delivery, diagnosis, consultation, treatment, transfer of medical data, and education using interactive audio, video, or data communications. But in reality, what the definition would be is it's interactive healthcare, typically using audio-visual high-definition communication, and we get the specialist to deliver care to a distant site. It's a typical model. Here's typical telemedicine equipment called a telemedicine cart. We have one here that we're going to have hands-on with after this talk, so you can actually see how it works. And so you have an originating site, which is a distant site. Here's his hospital in Douglas, Georgia, Coffee Regional Hospital. Dr. Deborah Lister here is on the board of the GPT. She is a major champion of telemedicine. She's the sole reason that there's so much telemedicine going on to Coffee Regional Hospital. And then here's a specialist at a distant site. So this could be a specialist, say, in Atlanta or in Augusta or someplace like that. Excuse me, I'm sorry. And so the specialist here can see the patient, and they can see the specialist at the other end. We now have all sorts of different attachments, what we call peripherals. And so we have cameras that attach to an otoscope, an ophthalmoscope, a dermoscope, which is what Dr. Lister was using. It has a wire that keeps the focal length correct for the macro camera to actually look at skin lesions. And we're going to demonstrate those, as well as Bluetooth digital stethophone, which transmits the patient's heart sounds and lung sounds to the device right here. And here's some images from telemedicine. And so here's an eardrum, here's a throat, here's an eye from there, here's a finger. And here's the image that dysmorphologists all get excited about, because we can sit here and see the fingerprints. And only true dysmorphologists know that this is pretty exciting, because this is his index finger. And he's got a whorl on his index finger, which is extremely rare. So how has telemedicine been used to provide genetic services? The system started in Georgia back in '93 or '94, and I heard about it and started thinking about it. And in 1995, on the original, was called GSAM's network, I started doing consults. And that network was quite cumbersome and expensive. It was a hub and spoke model, so MCG and Augusta owned the entire system, and everybody else hooked to them. That went away, and then Waycross, Georgia's health department wanted to continue having telemedicine, so they figured out how to use the internet back in like the late 90s to set up a secure linkage between us in Augusta and their clinics in Waycross, Georgia. So it was just a one-off telemedicine network at that time. So we kept doing consults with them. It was great. And then something came up called the Georgia Partnership for Telehealth, which is the network we have today that's been very successful. Matt asked me if I had a picture of all the sites on the map, and I said, well, it's old. And the reason for that is it's always old, because they're constantly adding sites. But you get a sense here of where they are scattered all over the state. Eventually, they should be in every county. The original vision of the network was that no Georgian would have to drive further than 30 miles to see a doctor. There are 350 current sites and 800 endpoints. So there are certain sites that have multiple rooms and places that are using it. And this is an interesting model because it's an open access network, and the lines are not showing up well. But basically, any of those sites in the network can connect to any other site on the network. So it becomes sort of a open access information highway that can be used. And in point of fact, if we go back to this, in Augusta, you know, we actively would use it. Our pediatric specialists were doing telemedicine. But if a request came in for a consult and, say, our endocrinologist says, well, I'm too busy, I can't do this telemedicine stuff, somebody in Atlanta could do that. It actually turned out there was a doctor who was a pediatrician who also was an endocrinologist who was in, what county is that? Anyway, he's boarded in pediatric endocrine, and he said, oh, you need some endocrine? Fine, I'll do it. So this guy who's in Jessup, Georgia, you know, becomes on the network, and he can see patients all around the state. What was really good about this network is I did telemedicine clinics from our telemedicine room in the pediatric clinic, and I would have patients scheduled, and I would like link to a patient in, say, Jessup, Georgia. Finish that session, say, who's the next patient? So I'd say it's in Tifton. I would just do a click to their IP address, and I'd be in Tifton, Georgia, seeing the patient. I could hop around 4 or 5 sites around the state without leaving my seat. So the openness of this network is really good. The other thing about the telehealth network infrastructure is that we have centralized scheduling. So referrals go to one central location, and they would then handle getting out to the specialists. They even worked it out that when they would set up a schedule for my virtual telemedicine clinics, that it would also populate my IDX appointment schedule at MCG. There's telemedicine liaisons. Shay Ross back here is your liaison here for Emory. And they're the people who help you get things set up, make sure things are working. If you have any technical issues during a session, you know, you contact your liaison. If you have technical issues that she can't handle, they can also get Jerry and his folks on the screen and troubleshoot whatever's going on if there's technological issues. I've only used Jerry once, I think, in all the time that I've been using the GPT network, so it's pretty robust. And they advocate for expanded reimbursement for telemedicine, issues like getting distant sites to be, you know, able to bill for their services and that sort of thing. So, on the Georgia Partnership Network, you know, I was seeing patients 2 half-days a month before I left. And I would typically have 5 patients per session. So I would, you know, like you usually do, schedule more than 5 for a session. The no-show rate ranged from 0 to 33% per clinic. So, you know, you don't want to overbook too much. As I mentioned, you could go to multiple sites. So a virtual clinic is simply a schedule. The patients where they are could be anywhere around the state, and you can go see them sequentially. Just pop in. Most of the patients I was seeing had developmental delay plus something else. So they were dysmorphic or had growth problems. You know, increased likelihood there is a genetic problem here. Typical for us, 75% were new consultations. And you know, you get the history, the family history, do the exam, explain things to the family, fax the lab orders to the facility. The diagnosis rate when I looked at it was the same as for on-campus consults. However, I never formally evaluated it because I would have had to go through 17 pages of IRB stuff in order to do that study. And I was rather happier just seeing patients and doing right. Now, the proprietary Waycross Telemedicine Clinic continued to this day. There's that fixed thing between them and us. And they had their own cart that we would roll out of a locked closet in our office area and connect to them to do it. And there were 4 to 6 patients scheduled. There was a 25 to 50% no-show rate, which is interesting. And once again, most of them were follow-up patients who I'd been seeing in the past, and they needed follow-up. And we'd go ahead and see them for these problems. Now, the thing a lot of people want to know, especially when you're talking to someone about you want to start a clinical service, they want to know about business plans, right? So I had our practice plan people back in 2012 do some analysis for me. And for all the telemedicine patients that I had seen in that year, the net collection rate was 100%. The net collection rate is what percentage of the dollars you should have received for your services you actually receive, because you never get your total charge with any kind of insurance contract. So 100% net collection rate is fabulous. If typical practice has an NCR in like the high 80s to 90, they're happy. You know, that's really good. But because of centralized scheduling, because of people and the staff getting authorizations and everything, 100%. The other thing people want to know is, well, how much are you getting? Our collections averaged $125.34 per patient encounter. So that was a mixture of new patients and old patients. So that's a mixture of some bills that are $350 for a level 5 consult, and others that are for, you know, a level 3 to 5 follow-up visit. So the lessons we learned from more than 15 years of telemedicine genetics is that genetics can be done by telemedicine. The quality interaction is good. The image quality is great. There are certain conditions that I would not want to see by telemedicine. Typically, they're conditions you need to palpate the patient. You know, so somebody who has a risk of developing a tumor, I don't want to see them on telemedicine because you have to examine them. You know, so a kid with hemihypertrophy or Beckwith-Wiedemann syndrome, you know, you really need to palpate their abdomen, even though they're getting imaging studies. You know, you just have to do it. Neurofibromatosis, I felt very uncomfortable also because a lot of neurofibromas you can't see. You have to feel gently because they're like subcutaneous. You'll notice in the previous slide from one of the clinics, I had seen a patient with Beckwith-Wiedemann syndrome, not by my choice. It just sort of like shows up. So in that kind of setting, we explain the limits of telemedicine and say, this is not the best way for us to see this patient. You know, this patient needs to be seen in person, but let's at least do a preliminary evaluation here, et cetera. And that was one of my cardinal rules with my other doctors at MCG was, if you're in the middle of a consult on telemedicine and you say this is not going to be medically appropriate, you have the right to say time out, you know, because we are not going to provide substandard care, you know, let alone the risk involved in that. Patients were very satisfied. We did formal assessments. There was great satisfaction. And then the show rates vary, as you saw, between those two clinics. And Carolyn Level, who was our genetic counselor, pointed out that the difference is whether somebody is enthusiastic at the other end about encouraging people about how cool it is to be seen by telemedicine, what a benefit is to them, as opposed to like, well, we can schedule for telemedicine, you know, kind of thing. And you get salesmanship. Other lessons, most patients and families, you know, really do well with telemedicine, but sometimes just not good. I had one time where the mother kept looking at the kid to answer the questions. Another time, this mother saw herself on camera and froze, you know, because she was unkempt, you know, missing a few teeth, and it was like, we went like, you know, whoever scheduled this probably should have thought, you know, about this mother. And so that coordination between the specialist and then the outside staff is very important. It worked so well for us because of the fact that we had local champions for telemedicine at distant sites. You know, like somebody's got to be telling the doctors that they can refer patients to be seen for this. And the people at the facility have to be really interested in committing the time to be available because the liaison is not going to be the person you can rely on to come present patients. They've got a whole territory they're covering. The open architecture I explained, you can hop around, so it's very efficient. And the big thing is that all payers in Georgia are required to cover telemedicine because the original vision of the network was set up by Commissioner Oxendine, who was the insurance commissioner. So needless to say, he was in a position to tell them, if you want to write insurance in this state, you will cover telemedicine. Other states don't have that benefit. All right, other use of the technology. Well, you could do follow-up a patient with inborn errors, and we've done that. The nutritionist, it's great for them because it's a lot better than talking on the phone to somebody. You see them face to face, and they go like, "Oh yeah, we're doing all this," and you can just see they're lying. You can tell, right? You don't hear it on the phone, but you can see it. And it also is better for the dietitian if you're counseling and coaching them to actually be able to interact with them. The problem is, dietitians wouldn't be able to bill and collect on this. If you could get a waiver for Medicaid, that might be something that could be worked on. Telemedicine for genetic counseling, cancer genetics, CF would be really nice and straightforward there. Other diagnosed things where you need counseling. The counselors in our state are not licensed. In other states in the region are not licensed. And even if they were licensed, they're not recognized as billable entities by payers. We tried visiting that a couple times. Untapped opportunity to store and forward telemedicine consults. And need to make sure that it's structured to meet a definition of practice of medicine that's recognized by state medical boards. Because the concept is simple. You get some image of some sort in patient records. We have the capacity in the GPT system to package all that securely and forward it on to a specialist who opens it up securely, can look at it. I've done this for several patients. And then you can send the consultation report back securely as well. In some states, that would not be considered practice of medicine. So I'm not sure in this state if that's covered or not, because at one point we had a code to bill for it, and the code went away. Okay, so it's once, yeah, okay. Yeah. But we try working with the state medical, composite medical board here, and we actually have some connections now, so that's good. There are challenges here, but it's worth the effort. Improved access, you get decreased cost of care because the patients, families don't have to travel, take off from work. The genetic consultants travel, you're not traveling. I mean, to go to Waycross is a 4-hour drive from Augusta. Gas is cheaper now, but still is expensive, and then you spend like a night in a hotel if you do it overnight, do 2 days. It's a green service. How do you cost the carbon offset with that as well? It gives you enhanced revenue because, if you're actually driving out to outreach clinics and you have all this downtime, there's time you might actually have been at the clinic, or at the hospital and been able to see a patient. And chances are they say, well, we sent that kid home and he's got an appointment to come see you. Will they show up or not? This way you don't leave your home base necessarily. And so I'm not very good at Photoshop. But you can't be in two places. Now, the future of telemedicine is school-based telehealth clinics. The child goes from their classroom to the clinic. They get seen by the doctor, a specialist, or a pediatrician, for acute illness. The child goes back to the classroom. The physician will fax the prescription if one's indicated to the local pharmacy, and the local pharmacy in Berrien County would deliver the medication to the school for the kid to take home with them. Matt actually was involved in setting that whole thing up. We could do follow-up visits like this for genetics. It would save family time and expensive traveling to see specialists. I guarantee it decreases no-show rate if the kid's in school and somebody walks them to the clinic. Yes.
So, in that model, do you need the parents' consent?
Yes.
It seems to me you're
Yes.
sending someone from the
The parents have to sign this in advance. It has to be sold to them by the principal and probably the PTA and Matt could probably tell you the whole story about how they worked that out. And then the local hospital bought into it too because they ended up saving their emergency room. How much? Yep. So the hospital actually continued supporting it, right? Right. Yeah. Enlightened self-interest really works. And school systems all around our state are implementing this. How many school-based telehealth clinics are there now? There you go. And then the future of telemedicine is mobile. So here's someone using a tablet. Last July, I did an acute consult from my dining room table in my apartment in Bethesda, Maryland, to a clinic in Honduras because I had a baby with ambiguous genitalia. I told my wife to cover her ears, even though I didn't think HIPAA applied to it, and Matt assures me HIPAA does not apply. The head of the state Composite State Medical Licensing Board was actually volunteering down at the clinic, and she assured me that I had no malpractice exposure or anything as well. So I felt good about doing this. But just using an iPad, it's just amazing how you can do this. Now, of course, I couldn't use the stethoscope and things like that on my iPad, but I didn't need that for this patient. And there are now people developing things like this is a product called HIPAA Chat, which is HIPAA secure video messaging with an iPhone, and another company called Capture Proof, and they basically are doing store and forward with smartphones. My vision for telegenetics came before I heard about Uber. I just want to let you know this. I promise you, it was my own idea. I actually came up with it at the ATA meeting in Austin, I think, because I was talking with somebody after my presentation. And so it's point of concern virtual consultations. So you've got the doctor has the patient in their office, and they have a concern. Say, well, maybe I should get a genetics consult. Well, what normally happens is they sit there and go like, yeah, okay. So then they would have to write something down, give it to their referral person, who then has to contact the specialist, get an appointment, then get the authorization, then get the family contacted, and then have them reminded to go visit the person. The whole concept here is that they would just use a telemedicine-enabled device and hit the geneticist on call button. The signal goes out to a network of geneticists who signed up to be available for consults, and one of them says, well, I'm sitting here in clinic and my patient didn't show up. Bam, I'm the person. I'm generating revenue here instead of sitting here playing on the computer or talking with the nurses. And I'm not good at PowerPoint, so I got the sequence here out of sync, but here was be the point of concern doctor, and then they send the signal out everywhere. And then somebody in North Carolina says, hey, hell, I just finished making rounds. I got downtime. I'm going to do a consult. And we can do this with the technology we have today, securely. The only concern here was how you get paid for it. That was your question. Well, if you can offer a service like this and you can talk to a payer and have them agree to a contract, that's how you do it. So this reduces barriers. You could probably increase the number of genetics consults. It increases your clinical productivity because everybody gets, holes in their schedule. Or my ultimate vision was I was going to retire and have a network of buddies who are retired as well. And, we just take turns being on call, and I just sit around the beach with an iPad. And oh, okay, I'll do that. Yeah. You could share a call schedule and day shift and night shift. Okay, thinking about telemedicine. The considerations you have to think about. Under current law, if you're going to do it cross state lines, you have to be licensed in your state where you are as well as the distant state. There have been some movement in that direction, but it's really not going to become a national license anytime soon, as far as I can tell. States have different rules regarding whether telemedicine is part of medical practice. We had been doing telemedicine in Georgia for years before somebody found out that telemedicine was not actually recognized as part of the practice of medicine. That was quickly rectified, fortunately. Some states have requirements that you can only do telemedicine after seeing a patient in person and establishing a doctor-patient relationship, which obviates the entire point of this. And people are working on that. Insurers or payers may not cover telemedicine services, so it's something to know about. A facility that wants to have this, you've got to have champions. You have to have a desire to use it. You have to have space. You have to have a budget to sustain the program. You know, you've got to have dealing with all the expenses of having the connectivity fee every month to the network. You have to have staffing. Then you have to have the training. The GPT can help with that. Alabama Partnership can help with that. You have to purchase the equipment or lease it from a company. You have to have IT people maintaining your network. And GPT will maintain theirs, but you've got to have people at your place maintaining yours. And then you have to, plan how you're going to do this and figure out. There are resources. The Southeastern Telehealth Resource Center is headquartered in Waycross, Georgia, but it covers I thought I had a picture of it. Anyway, they cover the Southeast region here. And so their purpose is to be a resource to help people develop telemedicine. They don't give you funding. They just give you advice and consultation. This is their webpage. And then they also have the National School of Applied Telehealth. And so there are online courses to train people in telemedicine and telehealth. They have a certified telemedicine clinical presenter certificate, telehealth coordinator certificate, telehealth liaison certificate. I keep telling them we need to develop something for physicians so that you have a certificate as a telemedicine expert. So then you get your credentials for your hospital by just presenting this certificate. So now it's time for a live telemedicine demo. I think we're absolutely on time because we got started 7 minutes late, so it was exactly a half hour. All right, so Matt or Shay, are we going to get this set up? Oh, okay, well, while she gets this set up, yes, certainly. Questions? Yes, ma'am.
Okay. Can you let me pass the microphone to you?
Oh, it's like
So,
Oprah time.
We have 15 offices on WebEx right now who are listening in today. So
Have you encountered resistance from patients who want a relationship with the physician, they want
Mm-hmm.
where they want to see the same physician, they want a face-to-face encounter?
Well, since I was the only person providing services, they had that one-on-one experience. It's really amazing. 2.5 years ago, some PR person at our hospital saw something about virtual medicine and contacted me, and I said, well, yeah, we've been doing it for a long time, and in fact, if this reporter wants to come tomorrow at 9, they can see telemedicine in action. And so she got permission from this patient and mother and sat in for the encounter and then interviewed the mother. I'd never seen the mother before. And she said, well, what did you think of it? She says, I thought it was great. And she said, I think it was cool. I could actually see the doctor, and I don't have to drive to Augusta. So there's very little of that resistance these days. It's sort of like people have gotten to where they really want this. Eric Topol's latest book is The Patient Will See You Now. He's getting to that thing where people are empowered. They want the doctor responsive to them, and they want it convenient for them. And this fulfills that. Now, there probably are some people who, want to be able to, hold hands and, shake hands, look you in the eye and size you up. I'm much taller than I look on the TV, for example. Next.
There was a survey done by Hawaii who has been using telemedicine. They actually did a formal survey, and their data, at least what they showed, actually showed greater satisfaction through telemedicine. They felt they had a focus. They didn't have to drive. There were some who were dissatisfied, but majority showed greater, which I was surprised by that data.
Okay. Other questions? All right. So Shay is going to start this up. Should I keep the microphone on here, or should we transfer it to her?
Why don't we do that? We'll see. Those on WebEx, we're going to be doing a live demonstration of some telemedicine.
And people can
equipment.
come up and stand right here,
Doing a
because I
second
want people to
presentation that we'll
have the
record
experience. Michael, you're the leader. You're the clinical leader.
Post on our website.
You're going to get to
when
hear
it's
the
available.
stethosphone.
So hang tight, and we'll pick up what we can on this live demonstration.
Yes, I can hear you just fine.
So Tommy, where are you located?
I am located in Waycross, Georgia.
Okay.
In the extreme southeast corner down here.
Okay. All right. And so you're going to demonstrate some of the peripherals?
Yes.
Okay. But why don't you first do this, why don't you ask him a few questions and see how natural the interaction is?
Sure, so how you doing today?
I'm doing well, sir. And yourself?
Okay.
You see, there's no dropout. It's fully interactive.
Yeah.
You know, like a lot of video conferencing things, there is that pause. This is natural, fully interactive. Okay.
Is this a clinic that he's in right now, or is it a house?
He's,
Your office.
In the office.
but you're in front of a cart that looks like the one that's in front of us here. Okay.
Yes, I'm
Okay.
in front of a car. Yes, sir.
Okay. And then can you demonstrate how the camera can, the interview camera can move around?
Yes, we can do that. We can pan the camera. Matter of fact, I'll give you a shot of outside the window.
Yeah, there you go.
Yes.
The lovely parking lot.
Down here in rural Georgia. Yes, sir.
Yep.
So
I-
would that be the same camera you would use to show, a patient, limbs, face?
But just for macro view, for like not for overall views, but we actually have small cameras that will go for macro. And, okay, so do you want to demonstrate the otoscope?
Yes, sir. I will do that. Okay. I'm going to capture and share some images with you all. And I will be using the AIO camera with the otoscope attachment. This comes right off and just attach it right on there. I'm going to show you an image of my right eardrum. Should be interesting, right?
Can you dim the lights?
All right. Here we go. Make sure my light is on.
Oops, well, we certainly dimmed it.
All right. Now I'm going inside my right eardrum. Well, my right ear, right? I'm not going inside the drum itself.
Very, very healthy drum. Lovely light reflex.
Yeah.
Isn't that good? I'm going to capture that.
And what he's doing is he can now capture this image if you want to store it and use it in any documentation of some sort.
All right, next I'm going to take the otoscope off, and I'm going to attach a 5-inch spacer bar to this, and I'm going to show you an image of the back of my throat.
And so,
Should be interesting as well, right?
yeah.
So far, you're pretty healthy.
All right, we're doing good so far. Here we go.
Uvula deviates a little bit. Very good.
Okay.
Capture that.
Yep.
Okay. All right. I'm actually leave this spacer bar, and I'm going to try to capture an image of my right eye,
Okay.
which is a little tricky because I do wear glasses. So the focus it might be a little tricky, but let's see how clear we can get it.
And so this could be looking at the surface of your eye, not at the back of your eye. He also has an ophthalmoscope attachment.
Is this being recorded somewhere, like stored at the same time?
When he says he captures it,
The whole session?
Yes.
Pretty good.
no. No. During a consult, no. We don't store the whole. They used to do that, and they would then have tons of files of the entire visit, and it's like, is that covered by, medical records? Who owns it? That kind of stuff. So that went away.
I'm going to take this spacer bar off. I'm going to attach a derma cap, 60 times magnification. And I'm going to show you an image of my left index fingerprint.
He's not the one with the whirl. There's another tech that has that.
All right, let's get that fingerprint. Okay, let's get that focused.
So you could use this if you wanted to look at somebody to see if they had sweat pores as well, if they're looking for ectodermal dysplasia.
And with one more click of this camera is actually able to store 4 images. I can just press my button again, and I bring all 4 images back up. And we can isolate an image, zoom in. Go zoom back out. Okay. And there they are.
Okay.
Okay.
Are we logged on for the stethophone? Okay. Is it on?
All right, next we can go on to the telestat.
Okay, hang on just a sec. She's got to activate it.
Hold on, I've got to get logged in as well.
Okay.
No problem.
Is there any kind of scaling device so that if you were measuring like macros or something like that, there any kind of scaling device for the imagery so the consultant who's off-site could see how many millimeters?
Right. I'm sure it's technologically possible. I don't know if it's built into the software.
Okay.
No, but he's talking about, say, like say a patient had neurofibromatosis. One of the criteria is they have to have 6 or more spots that are greater than half a centimeter in diameter.
Right, so in that scope, in that camera, there's actually a program that you can make measurement while you're doing it and draw on it, make notations, things like that.
Yes. I mean,
there are functionalities like that. If you would like to have kind of a draw on the screen type of feature, just like you would on WebEx or something like that, there are platforms out there that can do that.
right.
Or in the actual stored image file itself, of course, you can manipulate that. Over a live image, you want to have kind of a different kind of interface. It's a little more complicated, complex, but it's doable.
But I mean, typically there would be a nurse or some telemedicine
There's a person at the other
end,
Right.
and you could talk to them and say, "Could you get me a closer view
Yes,
of
that's what we
the
do.
toes?" Right.
That's what we
So,
do.
I mean, I think
Right.
that
And you always sit there and you say, like, would you turn the head to the side so I can see the ear? You know,
right.
you know, don't tell the mom to do it. You get the staff person at the other end who's the assistant for telemedicine to do that kind of stuff.
Right.
And they're the one who takes the stethoscope and moves it all to the points on the chest. So we're now set for the stethophone?
We are. So this is the Littman Telesteth. It connects via Bluetooth, and so we're connected to Tommy. Currently, he has the same programming as we do, and you can hear his heartbeat through this Steth. So if you guys want to listen.
We have alcohol wipes to clean off. No, you need to hear.
The Steth and like you were listening to someone's heart, and here is his heartbeat down here.
You hear it now? It's better. It's better. It's better. Right here. So, but yeah, so during the course of an examination, you give instructions to whoever is the assistant at the distant room. And, you know, especially with kids, you know, it's like sometimes you need a little more help holding the kid still and that kind of thing. We don't like to do it for kids under 2 years of age simply because of the fact that it is hard to keep them still. And if they're constantly moving, you can never get a good fix on them.
It should. You might need to step closer just if the Bluetooth connection is.
Is it on? Yeah, it's on. Go ahead. So you're saying that the dongle is on that side, so you may not be able to go too far. It's sort of like when you got your phone on Bluetooth on your car, you can't like walk out of your car and keep talking. You'd also hear lung sound very well. Our pulmonologists were skeptical of the whole system. We had them try it out, and they're now very excited because they don't have to go see CF patients all over the state.
Another cool feature just of the technology is if Tommy has the ability to click on these separate body images down here and change, we can change on the provider side where the actual Steth is placed on the patient, and he sees that in real time. So if there's a language barrier or something like that, you can interact with the presenting site without having to communicate verbally with the telesteth.
So in other words, what you're doing is you're saying, move the head of the stethoscope to this area here. So you're essentially picking the site, and they're moving it for you. It's okay. We don't have the virtual reality glove yet, unfortunately, because that would make the palpation part really possible. Apparently people are working on that kind of stuff, right? Yeah, yeah.
Have you thought about working with some of the ultrasound companies to try and interfacing?
Oh, they do.
They do already?
Yeah, there's a perinatologist in town here. What's her name?
And Peter, Patterson, Dr.
Yeah.
Patterson. She,
And
MF,
she's-
and Dr. At Midtown. We also have
All right, so they're doing live ultrasound
Dr. Page.
interpretation.
Emory Midtown. We do have portable ultrasound. That's USB port. My wife was a high-risk pregnancy, and we used it on the couch at the house just to track the baby every day. So these things are becoming more and more, and I could put it on my phone, and I knew the sex of the baby before we actually got to go to the doctor. So very cool stuff.
Okay, other questions? Okay.
So one thing I wanted, they also have a directory of all the providers, right? So, for example, they have a directory of providers. So, for example, if Dr. Gambella wanted to refer an endocrinology consult or something, so they can look.
Right. You contact the scheduling folks, and they do that. Conversely, you know, if you say, well, here's this patient, and we'd like to see them, but we can't get them in here for 3 months. You say, where do they live? And you can then check with GPT, and they can find out if there's a site close to the patient's home where they might be able to be scheduled to be seen. You can look at that in real time if you have access to it, or I'm a lazy person. I always just delegate it and say, call the folks at the 800 number. But they can figure it out. You know, they do it. And you know, it's always like an option if you want to do follow-up, for example. So you see a kid up here, but you say, well, let's do a follow-up, you know, but maybe there's a way to do follow-up in the home community, you know, and then you just check and keep your fingers crossed that it's one of the counties that has a telemedicine site, because not all counties do. But again, we actually had a kid one time, I think it was, we saw them at a nursing home site, because that was the closest to where they lived, you know, so the person who's support person at the nursing home site was not quite familiar with pediatric patients, but it worked out.
So I certainly can see how this is.
Can we turn the lights on?
How this is wonderful for families. I just saw a child yesterday, and you know, a young mother had a commute here from Savannah, and would have been great if we could have done this by telemedicine. One of the questions I have for you is, so you know, at the end of my encounter here, you know, I do a note.
Right.
And that note goes to this child's pediatrician.
Right.
About my recommendations for what they need to do in Savannah. Because I'm not going to orchestrate, you know, the renal ultrasound and all the other things that this child needs given his genetic problem. How do you deal with the documentation of this encounter? And
well, since at MCG, I was seeing them at the MCG telemedicine room in the pediatric clinic, and so I documented it in Cerner because that's where the encounter was occurring.
So after this, you just do what you regularly do. You
Yeah.
just go into Cerner and do your note.
Right. Now, there is also an EHR they're developing for the telemedicine network itself, right?
Just come up there. With us, that way we don't have to run you around everywhere. So if there is a site you're communicating with who, say like a school, or say a pediatrician's office that has something other than Cerner, Cerner now has the ability, because of meaningful use 1, 2, and I think they're working on 3 and 4 and 5 and 6 and all that. But it has to be able to send a direct message in a CCDA format or HL7 format to another EMR or EHR that can then accept that information. So there's still the old fax the document over, you know, once it's printed out from your database system, kind of the old-fashioned way. But then now you can send direct messages. We do have a EMR that we use at some of our sites that don't actually have an EMR that they can use for notating as a presenting site. Because as a presenting site, you can also bill for that patient. They can present it to you.
Sure.
Yeah.
They have to take the time out.
Right. They're working the patient up. They're doing some other things. And so, yeah, there's some need on both sides for that note to
Right. But the site of service is where you're practicing. So it's your record. But in an ideal world, we'll have the health information exchange process so that your note will immediately get transferred to the referring physician's EHR, which is what Matt's talking about.
So I had gone to see a clinician who's a psychiatrist at Emory,
Mhm.
who runs a clinic, telemedicine clinic, and she showed me that she was able to keep all the records, like MRIs, any reports, as a part of the chart record with this. Is that say, for example, the pictures that were taken today
Yeah.
as a part of the permanent
You could. You
Yeah,
could.
you can capture them into the file directly when you're stamping them, or you can pick the ones you want and pull them in and just save them as a
part of
save them as a JPEG or a large, raw file. And we also have an image grid for CT, MRI, ultrasounds. So say we have a stroke patient who presents in a rural hospital, and they're doing the CT, they're filling out the NH stroke scale information on their side, taking all the lab works, timestamps. The neurologist logs on, stroke specialist logs on, talking to the patient bedside, and then also reviewing all of the lab work, all of the CT images straight from the hospital itself within a couple minutes, and they can administer that TPA, that sort of thing. So that program we built over
3 years?
it was longer. I mean, we built that with Savannah Memorial
Yeah.
probably 6 or 7 years ago. Yeah.
How many providers can you have looking at the same patient at the same time? Like with genetics, you need neurology, endocrinology, cardiology, etc.
No one has ever worked out a really efficient multi-specialty clinic model in my experience. It would be interesting if you could do it virtually. Yeah, that would be. That would be.
We have a bridge, so you can do a multi-point call. So we all call into a specific virtual meeting room or VMR. You see this with like Google Chat, Google Talk, and all the you can call.
But those aren't HIPAA compliant.
Those aren't HIPAA compliant.
Don't even think of it.
The feature is very similar in that where we all call in. Say if there's 12 of us, 12 locations, we all call in, and we're like the Brady Bunch on the screen. Then someone has control of the desktop viewer, and they just share the image or share the cloud-based database.
Oh, that's right. Some people are doing tumor boards that way. Yeah.
They do one.
Yeah.
With,
Yeah.
Sites all around the state about once a month now.
Yeah. So they do.
Education.
Yeah, I mean, that's no different than having video conferencing.
Well, this is.
I mean, the tumor board, we
But
do
that's.
that now. We present cases and they're projected over to.
Yeah, but if you had a patient sitting there and you wanted multiple people working on that patient at the same time.
You could do it, and it'd be HIPAA compliant.
I
Yeah.
wonder if we can see if there's any WebEx participants have any questions.
Okay.
Loki, can you
Thanks.
do the audio? Go ahead and roll audio all the way off. Other button. To the right, that one. Okay. All right, are there any WebEx participants that have questions or comments?
Or comments. Yes.
Seeing none. Okay, all right.
How much is this cart? Now this is the Cadillac.
Yeah.
You got to understand, you could come in under that.
Yeah, I mean, we scale depending on the type of program. The physician side of the equation is very, very simple. It's a laptop, a camera, and a stethoscope. That's 90% of the physicians out there. Rarely do they sit in front of one of these.
Right, that's on the patient.
Right. This is more on the patient side, and even on the patient side, we've streamlined this down into a more mobile solution. So we're putting them in ambulances now. We're putting them in helicopters now. We're carrying them with us, and we're going into Honduras, Guatemala, Haiti. I'm going to Macedonia in the week. We're in China right now. We're doing some other things. So these things are becoming very mobilized because of the technologies. And then, of course, with consumers becoming more educated with this and home health peripherals being developed, it's coming very, very quickly.
So in other words, you may not need to have all the peripherals at a distant site. You pick and choose the components you want, and then someone can figure out what that'll cost. There are some companies that do just essentially lease it to you, so you don't have that capital outlay. You have a lease.
Yeah.
Yes.
What is the cost to the physician to be a member of this consultant?
To be on the network, there's a monthly fee of what? To be connected to the network. $200 a month. So with my experience, that'd be 2 patients a month covers your cost. And the rest is net margin, because we never say profit in not-for-profit healthcare. We always say margin.
So has anyone used any of these systems for research? So for example, you know, consenting patients
Mm-hmm.
for a research protocol where really only the investigators, let's say at Emory,
Mm-hmm.
are IRB approved to do the consenting. It'd be really nice to, you know, let's say there's a family in Valdosta or someplace far. I don't know my Georgia geography well that yet, but far. And but you know, their physician got them really interested in our research study, and so we would like to consent them and answer questions and have face-to-face contact. And
Mm-hmm.
has anyone used the system for that?
Yeah. Now, of course, but something more like the HIPAA chat kind of thing would be more conducive for that, for the poor pediatrician on the other end, rather than have to have.
Right, you don't need
Yeah.
all of the bells
You
and
just need the
whistles
secure
for that.
connection.
I mean, technically, you
Well,
could just use
and
Skype,
in fact,
but it's not.
I think
it's not
Sylvia,
secure.
I think Sylvia Mann is doing a project where they mail out the smartphone with secure messaging app on it to the families to participate in whatever their project is, because you know it's like, what's the cost to send FedEx? You know, $10 to send the phone to them, and at the end of the thing, they mail it back. Yeah.
So we are thinking of having a work group at our regional meeting, which is in July. I'll be sending the email out, and we are planning on inviting the group from Hawaii and you guys to our work group. You got it.
Yeah. Right. Yeah. Okay. Any other questions?
One other comment in relation to the process. So we talked about the video, and of course, be able to do a full history and physical examination. That's some of the state medical board rules around doing a billable encounter, a medical practice I guess, equivalent.
Mhm.
And then, you know, we also have the scheduling piece, but then the credentialing piece. Okay, so if Dr. Flannery wants to see patients at Coffee Regional, like that picture up there, he has to be credentialed there. So we also provide that level of resource to our sites to kind of speed up the process.
Right.
Because,
So in other words, I filled out one credentialing package, and they then use that on my behalf to go. I had privileges at about a dozen hospitals in the state. Right. And what's really interesting is I did, for some of them I had to get additional letters of recommendation, but you know, it's not too bad. What's really funny about the whole thing is that they then, at the end of my term of being on staff at that distant hospital, they say, well, you know, you can't have active privileges because you don't have enough patient volume. And it's like, guys, you know, like, that's not my problem. That's your problem. You know.
I think that's the problem with genetics, right? We have
No.
that problem.
No, this is just the basic.
Hospitals yeah.
The basic thing is that, you know, I didn't have like 6 encounters in a year, and so you can't be on the active staff if you're not being active.
Right.
And it's sort of like, I said to him, well, fine, find a category for me if you want me, you know, have a nice day.
Sure.
You know. Yeah.
I have one more last question.
Yeah.
You know, since it's such a federal mandate and they are considering looking at community health departments having this resource, the state investing in the equipment and technology rather than each institute, what is your current relationship in state of Georgia with the community health departments or other sites where Emory could collaborate?
well, we work with every state agency, from